The target uptake or coverage of a national population-based diabetic retinopathy screening programme is 80%. This is difficult to achieve. To achieve high coverage and prevent blindness from diabetic retinopathy, DR services need to ensure that the proportion of people with diabetes who do not attend their appointment for screening or treatment, the non-attendance rate, is as low as possible. However, many DR programmes are faced with similar challenges of high non-attendance rates for screening and treatment. A high percentage of non-attenders show symptoms of proliferative retinopathy when they do attend. And attendance for initial laser treatment is reportedly around 70%, but some studies have found 21 to 45% of people default and fail to complete their laser treatment. So why do DR services experience high non-attendance and acceptance rates? Is it due to the service provider, the patients, or both? To answer this question, we need to understand both patient and provider barriers to DR services. Across many eye clinics, it is a common administrative policy to discharge patients who miss 2 appointments. However, in DR services, it's important to find out and address the local barriers to attendance that people with diabetes are facing before removing them from the database. Evidence from different places has identified 7 broad reasons, listed under A to G, why people with diabetes do not come for their regular diabetic retinopathy screening. Lack of awareness about diabetes and its eye complications. People with diabetes may also not be aware of the local screening options available to them, or when to start attending. Beliefs. These vary from country to country, but reports indicate that people with diabetes without symptoms may believe they do not need retinal examinations, that they have mild disease, or that they are too old to interfere with their eyes. Cost is a repeated barrier, as people with diabetes experience both direct and indirect costs, such as travel to the screening centre. For some, the cost of managing the medications for their diabetes is already a challenge. Distance from the hospital or lack of transport remains a challenge in many regions, particularly for remote and rural populations. Screening camps and telescreening programmes are sometimes the only way to reach these people. On a practical level, discomfort caused by the dilating drops used in DR screening can also prevent people from driving themselves to the screening centre. Effort to attend yet another clinic for their diabetes management. People with diabetes often have multiple hospital appointments, and employers may not allow them to take too many days off. Fear of laser treatment and of its impact on their life and jobs. Family support is very important in coming to terms with possible blindness from untreated diabetic retinopathy. Guilt surrounding their personal failure to control their blood sugar levels, which leads to retinopathy and having to seek treatment. There may also be other barriers specific to your own setting. It is important to attempt to understand all the patient barriers to DR screening and treatment in each local setting. This enables providers to develop health education activities and appropriate services to support people with diabetes to attend DR screening and treatment. Actions that providers can take include raising awareness about diabetes-related eye complications through counselling and advisory services, having an efficient communication system or a call and recall system to enable people to come to screening and treatment, reducing long waiting times, and having an efficient referral system with services in accessible locations. Provider-related barriers to DR services are often due to weaknesses in 5 key areas of planning and management. Manpower. Are there enough trained personnel to deliver screening and grading services? And are there enough ophthalmologists trained to provide DR treatment services? Materials. Are there enough functional screening equipment and lasers? Management. Is there a good call and recall system in place and an efficient referral system for treatment? Motivation. Achieving high acceptance rates of DR services and thus effective prevention of blindness from DR is often a positive motivator for staff. It is essential to provide regular training support, especially for graders. Money. A screening service is a very expensive undertaking, and its sustainability will depend on the health system. DR programs need to take a multi-pronged approach to address provider barriers, improve service delivery and meet demand. Areas that need to be covered include recruiting and training staff, the supply, use and maintenance of instruments and equipment, establishing accessible screening services and supportive treatment centres, task shifting and taking a team approach to eye care, for example by having non-clinician graders, and maintaining an efficient call and recall system, and ensuring a good flow for people through the screening process to reduce waiting times. It is important for the planner or manager of a DR service to identify the local barriers. Sometimes provider and patient barriers need to be addressed to create demand and balance it with good service delivery. Considering the equity of a DR service is very important. Often, the most vulnerable people with diabetes are missed out from screening, for example the elderly or people with disabilities. Equity means providing DR services that are accessible to all people with diabetes within the local context and high quality across all settings. DR programs can provide equitable services using different models. Waiting at the centre can work if there is a good register of people with diabetes along with an effective call and recall system to track attendance. Supportive counselling for diabetes management should be provided alongside eye health information. In many places, such as India, DR screening in remote or rural locations is conducted through screening camps. Screening equipment is taken to the camps, and people with diabetes are given an appropriate eye health examination and referred as required. These services need to be regular and reliable for people to gain confidence in them. Mobile DR services are sometimes the most practical approach to reach remote settings. These can be exclusively for screening or for both screening and treatment. Telescreening with simultaneous grading at base hospital is another model in use. Referred patients may need to be provided with transport to overcome travel challenges. Equitable DR services can be implemented in various ways and in conjunction with other eye care services. For example, in the UK, optometry services on the high street have been used to screen and refer people with diabetes for DR services. Finally, centralised services combine DR screening along with regular diabetes checks and blood pressure monitoring, and can be useful to manage bookings and to reduce costs, both for hospital administration and for people with diabetes. In summary, we need to understand and address the barriers experienced by people with diabetes to increase coverage and attendance rates of DR services. Eye units also need to assess their own efficiency and effectiveness in providing DR screening and treatment. Both patient and provider barriers to DR services must be understood and managed in the local setting to achieve a coordinated and sustained increase in both early detection of sight-threatening diabetic retinopathy and the provision of appropriate treatment.